Now let's interpretation. Interpretation. So the interpretation, okay. So presence of at least 4 criteria out of the 11. Presence of at least 4 criteria out of the 11 is diagnostic of SLE. Presence of at least 4 criteria out of the 11. Presence of at least 4 criteria out of 11 criteria is diagnostic of systemic lupus erythematosus. Is that we clear on that? Okay, let's look at the second criteria. The second criteria, we'll call it EOLA ACR. EOLA meaning European League Against Rheumatism. Okay, European League. European League Against Rheumatism. European League Against Rheumatism. Then we know the ACR, American College. They came together and they constituted this criteria. And I told you this criteria came into being in 2019. Okay? Someone can get a picture of this, okay, and put on the page so that you inscribe that in your notes. So the EOLA, okay, is made up of, here's how it is. It has 2 criteria under it. Okay, it contains what you call the entry criterion. The entry criterion means that should you do anti-nuclear antibody titers, okay, and it's greater than or equal to 1/80, okay, it's greater than or equal to what? 1/80. Then what does that mean? If you have something like, what will you think of? You suspect what? SLE, yes. So suspect SLE and proceed to the additional weighted criteria. So the entry criterion is very important. If the entry criterion is not fulfilled, you don't proceed. It means there is no SLE. You will not suspect SLE. Is that clear? Are we following? If the anti-nuclear antibody titers, okay, are greater than or equal to 1/80, then suspect SLE and proceed to the additional weighted criteria or the additive weighted criteria. The picture has been put. Have you seen it? You put the picture. Yes, that's it. That's it. So if you watch the picture there, you realize that the first thing there is the entry criterion. It has to be what? Fulfilled first. Okay. So if the entry criterion is fulfilled, that is the ANA titers greater than or equal to 1/80, you suspect SLE, then you proceed further to the additive weighted criteria or the additional weighted criteria. Okay. Are we getting that? Then the additive or additional weighted criteria, okay, it also contains 2 criteria under. The first one is the clinical weighted criteria, which is made up of 7 components, as you can see in the picture there. It has 7 components. We have some things like we have some of the components being the constitutional, where you have fever. You can think of the renal, okay, You can think of the serositis. You see, most of the things in the ACR criteria are embedded here as well. Is that clear? So yeah, it has 7 components, and you also have the immunological weighted criteria. Immunological weighted criteria. That one has only 3 components. Please, can you see that? Can you see that in the picture? Can you see that? Immunological, where you'll be thinking of the complement, okay, the C3 and the C4s. There's a complement there, right? The ANA is there again. Okay, you can see, as you can see here, you have the antiphospholipid, the complement, and the SLE specific antibodies, which you mentioned as the anti-double stranded DNA and what? The anti-Smith. You can see them there. The SLE specific antibodies. Okay? So that's what we are saying, that there are 3 components under the immunological weighted criteria. Okay? The complement, the antiphospholipid antibodies, and also the SLE specific antibodies. The entry criterion is what? The ANA. So the ANA will not be found in the additional weighted criteria. Is that clear? But the entry criterion must be fulfilled first before you can proceed to the additive weighted criteria or additional weighted criteria. If it's not fulfilled, then it's not SLE. In that case, SLE is ruled out. Is that clear? Now let's interpret. Let's interpret this. So the interpretation if entry criterion is fulfilled, if entry criterion is fulfilled, then there are additional weighted criteria and additional weighted criteria is greater than or equal to 10. What do you think of? It's diagnostic of what? SLE, okay? Yes, are we following? Are we getting that? You don't get it. So if the entry criterion is fulfilled, meaning that if the ANA is greater than or equal to 1/80, and you come to that additional weighted criteria, it counts with scores. Fever has its cause. Okay, the presence of the SLE specific antibodies also has its cause. So if you add those scores and you get at least 10, then you add it to the entry criterion, you have diagnosed what? SLE. Do you understand? Yes. This is that clear? Is that clear to you? Okay, let's move on. Let's go to the investigations that we can do. After the investigations, we'll talk about the complications of SLE. Then we'll move straight to the treatment. Then after the treatment, we'll look at drugs-induced lupus. Then that will be it for SLE. We'll take some short break, and when we come back, we'll look at multiple myeloma. Today we'll just finish with multiple myeloma because of the time. All right, let's try and see. Let's go to the investigations. Investigations. So with regards to the investigations, 1, you can do full blood count. What will you find? What will you find? Eh? Which? Won't you have anemia? What else do you have? You have leukopenia, right? We said those already. WBC less than 4 × 10⁹ per microliter. There will be what? Lymphopenia as well, right? There will be thrombocytopenia. So it means that you are looking at the HB, you are looking at the WBCs, you are looking at the lymphocytes. Then you are looking at what? The platelets. BE and creatinine. What will you do BE and creatinine? What will you do BE and creatinine? Yes, to assess renal function. Why? Because lupus can cause a renal disease. Okay. What else can we do based on the things that we've said so far? We can do ESR. Okay. ESR will always be elevated. Okay, elevated. CRP will be what? Normal, except in cases of what? Infections, like the serositis. Okay. Except in cases of what? Infections. Yes. Yes, we can do urine RE as well. Urine routine examination. And what are we going to find? We will find the granular. We'll find the proteins. We have the granular cast and the granular cast. We have the RBC cast. Okay. Yes, that's urinalysis. Yes, which other investigation can we do? Yes, excellent. So we can check for the serum autoantibodies. We know them, right? We know them. We can think of the ANE, which is the most sensitive. We said that, most sensitive. Anti-DS-DNA, double-stranded DNA. We said specific. Anti-Smith, which is the most specific. We also said the antiphospholipid antibodies. That's right, antiphospholipid antibodies. And we already stated that the antiphospholipid antibodies consist of the anticardiolipin, the lupus anticoagulant, and the anti-beta-2 glycoprotein 1 antibodies. We said that, right? Yeah. We can also check for the anti-SSA, which will be the anti-Ro for Sjogren syndrome, anti-SSB, that is the anti-La, again for Sjogren syndrome. Okay, anti-ribonucleoproteins, again ribosomal proteins. Is that clear? We mention of all that. Another one we can do what? A joint radiography, right? Yeah. What will be your finding? Your finding will be what? A periarticular osteopenia with non-erosive soft tissue swelling. So that's right. Joint radiography, your finding. Periarticular osteopenia. With non-erosive soft tissue swelling. Non-erosive soft tissue swelling. With non-erosive soft tissue swelling. Non-erosive soft tissue swelling. Okay? And if I say periarticular, you will see hypodense lesions. Hypodense. Okay? Hypodense lesions. Okay? Which other investigation can we do here? ECG. Well, that is if you are thinking about with regards to what? Eh? Why are you doing an ECG? Well, it may be done ECG. That's the cardiac manifestations like pericarditis. Okay. Why we do chest X-ray? If there are complications of SLE like pleural effusion. Okay. Are we getting that? Pleural effusion. Yes.
Concerning the serum auto antibodies.
Yes.
There's a question I saw and they said this is used in a confirmatory test for SLE, ANA and ESD.
No, it's ANA. When it comes to confirmation, ANA. I told you it's the most sensitive. Even when you watch the YOLA and the ACR criteria, the ANA is the entry criterion. Okay. All right, let's move on. That's fine. Let's move on. Let's move on. The next thing we want to look at is the differential diagnosis. Differential diagnosis. After the differential, then we'll look at the complications. Then we'll move ahead and look at the treatment. Okay. So the differential diagnosis. Differential diagnosis. Differential diagnosis, think of Sjogren syndrome. Sjogren syndrome, that's why you saw some of the antibodies here in what? SLE, because they are associated. Okay, Sjogren syndrome. You can also think of scleroderma. And scleroderma is characterized by, it has manifestations which can be clustered together, called, yes, who knows? Rett syndrome, which is made up of. This is only one person. Yes, that is correct. Calcinosis, Raynaud phenomenon, esophageal dysmotility, sclerodactyly, and telangiectasia. Yes, that is correct. And that's why you can think of polymyositis, dermatomyositis, where we said that for dermatomyositis, the nasolabial folds won't be spared. Okay. Antiphospholipid syndrome. Antiphospholipid syndrome. For the antiphospholipid syndrome, they will cause what we call, causes clot. When we say clot, it's an acronym. Okay. The first one will be coagulation defect. And next one will be livido reticularis, and racemo. Okay, racemo. This one will be more common in the livido racemo will be more common in antiphospholipid syndrome than what? The livido reticularis. Okay. So when we say, you should know that simply when you say livido reticularis, it has to do with what? Spasms of the blood vessels closer to the skin surface, which will give a net-like cyanotic pattern. You know, if the vessels are spastic with blood flow, when you see the area will become blue. So you have this red, you have this blotched red bluish to purple lesion, okay, on the skin, which gives that net-like cyanotic pattern. Because it's net-like, that's why I'm saying reticularis. Okay, but it will happen mostly in the acute phase, and the livido reticularis is not the most common skin finding that you have in antiphospholipid syndrome. It will rather be the libido rasmo. Exactly. Then, can you think of obstetric complications? Obstetric complications, we are thinking of miscarriages. Then thrombocytopenia. And if you want to treat this, mostly you have to give anticoagulants. Exactly. Yeah, you have to give anticoagulants. Okay? Exactly. Another differential that we can think of, Lyme disease, which is caused by Borrelia Begdoferi. Which other differential can we think of? We mentioned a lot of things. What else can we think of? Yes, rheumatoid arthritis. And what else? Rheumatoid arthritis. Okay, that's fine. Okay, so these are the differentials. Let's look at the complications. After the complications, we'll look at the treatments. Okay, the treatment. We'll be looking at the classes of medications and examples. Then after that, we'll look at what should be used, okay, for a particular condition. Okay. So complications. First one, you can think of renal disease. In that case, we are talking about what? Lupus nephritis. You should know that renal disease is the most common cause of death in a systemic lupus erythematosus patient. The most common cause of death in a systemic lupus erythematosus patient will be what? Renal disease. And in that case, we are talking about lupus nephritis. Please, are we getting that? What will be the choice of treatment here? Yes, anyone? It will be what? No, the lupus nephritis. Yes. Yes, the steroids. And next one, cardiac disease. For cardiac disease, you can think of what? Pericarditis. And you can also think of Liebman-Sack endocarditis. What is Liebman-Sack endocarditis? So Liebman-Sack endocarditis is a sterile, non-bacterial. Please don't ask me to repeat again. Just make sure you're writing. A sterile, non-bacterial thrombotic. A sterile, non-bacterial thrombotic endocarditis. Secondary to what? Inflammation. Endocarditis. So a sterile, non-bacterial thrombotic endocarditis, secondary to inflammation. Are we getting that? And caused by systemic lupus erythematosus, as you can see. Okay. And you should know that is the most Liebman-Sack endocarditis. It is the most characteristic cardiac manifestation of SLE. The most characteristic cardiac manifestation of SLE. Okay? Liebman-Sack endocarditis. Please, are we clear on that? Are we clear? Of course, they are affected. The mitral valve will be affected. There is endocarditis. endocarditis, it extends and covers the mitral valves. So the mitral valves will be affected most in this scenario, including the atrial surface of the mitral valve and the ventricular surface of the mitral valve. Okay. The next one will be pulmonary disease. Pulmonary disease. For the pulmonary disease, you can think of pleural effusion. You can also think of interstitial lung disease. You can also think of pleuritis. Pleuritis. Cerebrovascular. If you look at CNS, what will be the manifestation? CNS. Yes, stroke. And also, let's say cerebrovascular. Okay, let's say CNS, let's say cerebrovascular, so that we can add retinopathy here. Okay, cerebrovascular disease. So you can think of stroke. You can also think of what? A retinopathy. The retinopathy. These are these are some of the complications. The complications of systemic lupus erythematosus. Now let's move ahead. Let's go to the treatment. First of all, let's look at the classes of medications. The classes of medications. And examples. Classes of medications and examples. So the first class, call it the disease modifying anti-rheumatic drugs. That's what we call the DMARDs. Disease modifying anti-rheumatic drugs. Disease modifying anti-rheumatic drugs. For the disease modifying anti-rheumatic drugs, there are two types. Okay. There are two types. We have the biological DMARDs, and you have the non-biological DMARDs. Okay? So the biological DMARDs, you can remember using this. So biological DMARD, we can remember using bright. Okay, so example, we should know that the biological DMARDs they are made up of monoclonal cells. And I said to remember the examples. Remember bright, spelled this way. Okay. So examples: belimumab, rituximab, infliximab. These are the examples in general. adalimumab, tocilizumab, we have etanercept. So these are the examples of the biological DMARDs. The non-biological DMARDs, the examples, you can think of SHAM. Remember the Shamrod triangle, the Shamrod window. When we're talking about clubbing, Shamrod. So we'll get the acronym from this. SHAM or SCAM or SHAM. Okay. So in that case, examples: sulfasalazine, cyclophosphamide, cyclosporine, hydroxychloroquine, azathioprine, methotrexate. You can also think of mycophenolate mofetil. So these are the examples of what? The disease-modifying anti-rheumatic drugs. Okay? Did we get that? We said the biological DMARDs, the non-biological DMARDs. The biological DMARDs are made up of monoclonal cells. To remember the name, remember bright: belimumab, rituximab, infliximab, adalimumab, tocilizumab, and etanercept. When you go to the non-biological, think of what? SHAM. When I told you Shamrock window. So SHAM: sulfasalazine, cyclophosphamide, cyclosporine, hydroxychloroquine, azathioprine, methotrexate, and what? Mycophenolate mofetil. Mycophenolate what? Mofetil. Okay. Let's go to the second class of drugs. The second class, very, very common, is NSAIDs. Non-steroidal anti-inflammatory drugs. Yes, which of the NSAIDs is considered as the one to block cyclooxygenase 3 pathway? Which one is considered to block cyclooxygenase 3? Yes, paracetamol. That's correct. Paracetamol. So the NSAIDs, examples, you know them, you've been taking them, right? Yes, what do we have? Diclofenac, naproxen, what else? Naclofen, endomethacin, what else? Ibuprofen, etc. Then the last class is what? The corticosteroids. Corticosteroids. Examples: prednisolone, methylprednisolone, and the last one, prednisone. Yeah, right. Okay, so these are the classes of medications that can be what? Used in the treatment of what? SLE. Now let's look at the when each and everyone is each of them, which are indicated for a particular case. So for the treatment, in the first category, in acute flares, what is done? Acute flares, you would have to use IV. Which drug will you use out of the you'll be using the non-biological disease-modifying anti-rheumatic drug. Which of them will you use? Yeah, so you'll use IV cyclophosphamide plus high dose, plus what? High dose steroids. It's for acute flares, okay? For acute flares, okay? If you go to the acute flare, I mean, in this case, we are talking about moderate to severe, okay? Moderate to severe cases. Then the next one, if you have mild or chronic flares, well, let's put it this way. Mild flares or chronic disease, then what are we going to do? That's why we are going to be using what? Hydroxychloroquine plus what? Low dose what? Steroids. Then, if you have a relapsing disease, what will be the drug of choice? What will be the drug of choice? Yes, belimumab. That's correct. Belimumab. In the mild flares or chronic disease, sometimes the low dose steroids may not be efficient. It could be substituted with what? Belimumab. Okay. Is that clear? Is that clear to you? Now let's talk about drug-induced lupus. Drug-induced lupus, and that's where we are going to end the topic systemic lupus erythematosus. Okay, drug-induced lupus. Okay, drug-induced lupus. Okay, let's move on. I should go to this side. Let's talk about drug-induced lupus. So drug-induced lupus, as you can see from the name, is what? Caused by what? Drugs. Okay. So drug-induced lupus is caused by, okay, greater than 80 drugs. Okay, 80 drugs. Now let's look at the drugs that cause. We are just going to look at the most common drugs. Okay, that will be causing the most common drugs. Most common, right? Hydralazine is the most common, right? Then we can also think of procainamide. No, let's go according to what we think. Okay. Isoniazid acid is also there. Procainamide. Procainamide can also give you what we are talking about. You can think of anti-tumor necrosis factor agent. Anti-tumor necrosis factor agent. Oh, sorry, there's something we are supposed to add here. Before the anti-tumor necrosis, phenytoin. Phenytoin can be considered as well. Then which are the common, what am I saying? I'm saying that in which condition is chlorpromazine used? Who knows? Who knows? Where's what? Schizophrenia. Chlorpromazine. Schizophrenia. Is that? Anyone? Schizophrenia patients. Alright. Now, for drug-induced lupus, as we said, for drug-induced lupus, clinically, the lung and skin manifestations prevail. Okay, you should know that. Clinically, lung and skin manifestations prevail. But in this case, renal and CNS renal and CNS. Okay, manifestations. Usually absent. Renal and CNS manifestations are usually absent. The lung and skin manifestations prevail in drug-induced lupus. Is that clear? Now, for the diagnosis, we agree that the anti-Smith antibody is the way to go. We always said, for the anti-Smith, it is present in greater than what? 95% of drug-induced lupus cases. It is present in more than 95% of drug-induced lupus cases. Yes, please. Sorry. Antihistone. Sorry. Antihistone, we've already said that. Sorry. Antihistone. Okay, that's the anti-HO. So the antihistone, sorry for that. Antihistone antibodies are present in greater than 95% of all cases of drug-induced lupus. So what you are going to be checking for is what? The antihistone. Is that clear? For the treatment, so the disease will remit. It means it will resolve upon what? Withdrawal of what? The causative drug. Remits upon withdrawal of the causative drug. So the moment you remove the drug, you withdraw, you stop the drug causing the drug-induced lupus, the condition will start what? Resolving. Please, are we clear on that? Are we clear? Yes. There are a lot of them. Yes, there are a lot of them, but these are the common ones. We said more than 80 grams. I don't say you guys have so we just have to look at some of them, which are very common. Please, any question?
So, if you want to this person, what is more than one?
No, single-handedly, yes, they can force. So if you are talking about hypertension, side effect of hydroxyl, one of them is SLE, where they cause drug-induced lupus. Are you getting that? So single-handedly, a drug can cause or combination. Any more questions? All right, thank you very much for your attention, and we'll meet another time.